Dental College lecture cast in dental implantology. Today our topic is the treatment planning. Treatment planning can be broadly classified into partially edentulous and completely edentulous. In partially edentulous, the anterior or the aesthetic zone plays a vital role. Providing an aesthetic outcome requires understanding of the objective and subjective criteria related to the hard and soft tissue. A patient aesthetic expectation may also be evaluated together with their lip activity and lip length. A high smile line poses considerable challenge when planning for implant-supported restoration in the aesthetic zone because the restoration and the gingival tissue are completely displayed. In relation to the posterior quadrant, we need to be careful about the anatomical landmarks. In completely edentulous, we have fixed and removable option, where the classification was given by Carl Ehman in 1989, which is divided into FP1, FP2, FP3, and removable processes are RP4 and RP5, which we shall discuss later. And these are the few pictures of the patient. As we mentioned before, the patient evaluation depends upon the smile line. As we know, smile line is divided into high, medium, and low. Tooth needs to be evaluated in 3 planes of space: apicocoronal, facial-lingual, and mesiodistal. The existing tooth position will significantly influence the presenting gingival architecture. A tooth position more lingually would benefit from the presence of an increased amount of the facial bone. The root position of the adjacent teeth. Then we need to be careful about the adjacent tooth and root and need not damage during the placement of the implant. Biotype of the periodontium and tooth shape. The position of the gingival tissue around the tooth is determined by the connective tissue attachment and the bone level. And it is divided into biotype 1 and 2, whereas 1 is thin scalloped periodontium. A thin biotype with highly scalloped tissue will require the implant body and shoulder to be placed more palatally to mask any titanium show through. And this is the biotype 2, which is thick and flat periodontium, and it's characterized by a dense fibrotic soft tissue curtain, a flat, thicker underlying osseous form, and an increased quantity and quality of the attached keratinized gingiva. Loss of interproximal tissue in the presence of a triangular tooth form will display a wider black triangle than in the situation with the square tooth in present. The bony anatomy of the implant site. The facial lingual bridge anatomy should be evaluated, and the mesiodistal space should be equal to that of the contralateral tooth to determine if there is sufficient crest width to house the implant. And the position of the implant should be placed 3 to 4 mm apical to the existing free gingival margin as shown in the diagram. Then ideal implant placement should be palatal to an imaginary line that outlines the curvature of the tooth. Treatment planning for the posterior quadrant. In general, it depends on the available space. As we mentioned before, the mesiodistal, buccolingual, and occlusal gingival space has to be evaluated before the placement of the implant. Then the treatment implant number and implant position. Implant should be placed at least 1.5 mm away from the adjacent root, and there should be a space of 3 mm between the implants. The number of implants is dependent on the bone quality and quantity. So in maxilla, due to limitization of the sinus, inadequate space sometimes exists for placement of the implant in the posterior maxilla, as you can have a look at the diagram. The sinus augmentation allows implant placement, but the restorative space remains the same. So here there is implant placement with the sinus floor elevation and the bone graft shown at the time of the dental implant placement. And in maxilla, in case if sinus augmentation procedure is avoided, the placement of the implant in the maxillary tuberosity can be done. And implant position in mandible. So just have a look at this video. After the tooth extraction, there is bone resorption, and then the placement of the implant without proper evaluation. So this requires a shorter implant or a bone graft is required. Next, treatment planning for an edentulous mandible. As we mentioned before, it can be fixed or removable. Before the thing, 2 words have to be introduced here, that is anterior posterior spread or an AP spread. This is the distance measured from the center of the anterior most implant to the distal aspect of the posterior most implant. It ranges from 1.5 to 2 mm, but as shown in the figure, you can see x, which is the anterior posterior distance, and 1.5x, where the number of cantilevers has to be placed, can be evaluated. And the next word is jaw flexure. It is the primary cause of the posterior implant loss in full arch mandibular processes. Body of the mandible flexes more when the size of the bone decreases. And the prosthetic classification for treatment planning, which is given by Carl E. Misch in 1989. And FP1, little or no atrophy, allowing prosthetic crowns similar to those for natural teeth with periodontal health. The main goal of FP1 process is to restore a missing tooth that simulates a natural tooth. FP2 process appears to restore the anatomical crown and a portion of the root of the natural teeth. But the disadvantage is the restored tooth looks unnatural with excessive vertical dimension. It looks awkward in patients with a high maxillary lip line, so this should be noted before the fabrication of the prosthesis. FP3 appears to replace the natural teeth crown and has a pink colored restorative material to replace a portion of the soft tissue. But however, there are two approaches for the FP3 prosthesis, a hybrid restoration, which you can have a look at the diagram, and a porcelain metal restoration. The primary factor that determines the restorative material is the amount of the crown height space. Next, the removable option, that is RP4, completely supported by the implant teeth or the both. The advantages, usually RP4 has more implants with little or no cantilever, and the overdenture attachments permit improved oral hygiene or allow the bruxist patient to sleep without the excess forces on the implant. The last one is RP5, which is a removable process combining implant and the soft tissue support. Advantage is cost effective and it looks like traditional overdenture. But disadvantage, bone resorption continues as in soft tissue bone areas, and bone resorption is 2 to 3 times more than RP4. And these are the removable options with the overdenture, that is a bar type and the ball type, which is widely used. Overdenture 2 with a header clip. And this is the attachment should be positioned to allow the movement of the distal section of the prosthesis, which is an RP4 example. And 4 implants are placed in A, B, D, E position where it supports the distal cantilever. Of all, informed consent of the patient should be taken before any surgical procedure. Thank you.